Hi, everyone. We'll go ahead and get started. I would like to invite Dr. Sanchez just to say a few words just about our Heritage Month and our activities.
Well, good afternoon, everyone. It's a pleasure seeing everyone at noon. I'm Dr. JP Sanchez, and I have the honor and privilege of serving as the Executive Associate Vice Chancellor for the Office of Diversity, Equity, and Inclusion at HSC. As you all know, Asian Pacific American Heritage Month is one among 6 Heritage Months that we as our community are celebrating, and I'm so grateful for the leadership of Dr. Joyce Pang and our special guest, Dr. Ko. So without further ado, please, Dr. Pang, introduce us to the session.
I would love to. Hi, everyone. My name is Joyce Pang. I'm one of the surgery residents, and it's my pleasure today to introduce our speaker, Dr. Michelle Ko. Dr. Ko is an assistant professor in the Division of Health Policy and Management in the Department of Public Health Sciences at UC Davis. Her research examines the interconnections among policy, healthcare, and U.S. social structure. Her research spans topics from structural racism, health and aging, the healthcare safety net, Medicaid, long-term care, access to healthcare for minority populations, diversity in medical education, and the healthcare workforce. Today, she'll be speaking to us about the topic of the not underrepresented minorities, Asian Americans, diversity, and admission. Dr. Ko?
Thank you so much to Dr. Pang and to everyone at University of New Mexico for inviting me to give this talk. It's really quite an honor. Today we'll be presenting sort of the main points in a commentary that I wrote with my colleague, Dr. Henry Tan, about this topic. He's our Vice Chancellor of Diversity, Equity, Inclusion at UC Davis Health. And then updated it because we started writing it probably 2.5 years ago. The knowledge base has changed. My own knowledge has grown. I think the way people think and talk about these issues has certainly evolved, particularly in the past year. And as Dr. Pang mentioned, I do want to say up front, I'm a professor in health policy and management. And my background is not in Asian American studies. So this has been a learning experience for me. I came into this topic because I have spent a couple decades now thinking about workforce diversity, and particularly with respect to those who are underrepresented in medicine. How I was inspired to, think and write about these issues was, and I'll talk about this a little bit more later, was there were a new set of college admissions court cases that were coming up on the horizon. This is not new. This is started particularly with respect to affirmative action. The first major case was against my own university, UC Davis School of Medicine, back in 1978. But what was new was in these latest round of cases, they were brought purportedly on the behalf of Asian American plaintiffs. And the argument that affirmative action programs harm Asian Americans. And as someone who has studied this for quite a long time and thought about it, it was really frustrating. And I felt that we needed to, it reflected just in general that we have not had, I think, enough conversation about figuring out what are we going to think through as the positionality of Asian Americans in medicine. So let's see. This is a photo and from a video essay that was in Time magazine over 1 year ago. So as you can see, this is in April. And it was a video essay by a hospitalist named Chen Fu, who was at that time in the midst of the first wave of the pandemic in New York City. And it was a little bit of a video diary of his day about how hard he was working to both care for patients and then the racism he was experiencing as he went about throughout his day as well, and juggling the two of them. And since then, there's certainly been a groundswell of recognition around what might have really been happening for quite a long time in terms of discrimination, episodes of hate, and so on against Asian Americans. And certainly after the Atlanta shootings, things changed, I will say. For example, I knew right up until that point, there were DEI leaders at different schools of medicine and healthcare institutions who had brought up to their leadership, we should talk about this. And a number of times I had colleagues who said, well, this isn't really our business. And so it just shows that, our country, our dialogue is just not that sophisticated. And in medicine, certainly trying to juggle this seeming paradox of we have high representation as well as hate and discrimination at the same time. So the plan for today is just to kind of start some of that dialogue. Like any one of these sessions, I'm sure, as you know, is just a beginning. It's a jumping off point for more discussion. So first, I'll talk about how Asians are considered a non-minority minority, and drawing some from Asian American scholars about racial triangulation. Then I'm going to talk a bit about this issue that brought me to here, which is what is the position of Asian Americans when we talk about admissions in higher education and diversity. I'll move then specifically to some research on Asian Americans within medicine. And then we'll talk about one thing that everyone has been calling for quite a long time, which is disaggregation of data and what that means and why. And then the last part, though, I'm hoping I will finish talking within sort of half an hour to 40 minutes. I want to spend the last part where I'm going to put you into breakout groups, because I think ideally what we have is time for you all to get together and think about what you would do at your institution, and strategies that we can do to bring more inclusion, but also this sense of understanding that Asian Americans should also be involved in DEI work. So let's see. Find my cursor. So this is a graph about over 20 years ago. There's one of the Asian American studies scholars named Claire Jean Kim. She articulated this idea of racial triangulation that she has trying to advance, in discussions where a lot of race discussions in this country are about white versus Black residents. She proposed that Asians occupy this middle triangular position where, on the one hand, Asian Americans are praised as a monolithic group in what she calls in a way of relative valorization. And the work of that is to do that in a way to oppress other groups, that you relatively valorize Asians as a flip side of your other narrative about oppression, about the inferiority of other minorities. But at the same time, Asian Americans do not get full participation in society, so there is still also a work of civic ostracism, right? And this is why there's a foreigner to insider access, where Asians are still placed on the foreigner access. And so what are those things? So those, of course, are the theoretical terms. But what does that mean sort of, in real life? Civic ostracism, the classic example for Asian Americans is going back, a couple centuries of this idea of yellow peril, that people from Asian origins are bringers of disease, that they are not clean, that they should be associated with infection. And that goes all the way back in American history as well, from, raising and isolation of Chinatowns to currently today. These are the findings from, surveys done most recently around asking people of different racial and ethnic groups, have they experienced negative experiences from the start of the pandemic? As you can see, when we talk negative experiences, might be fear of physical harm, being subject to racial slurs and jokes. And so as you can see here, the blue dot is Black Americans, who are over half have experienced at least one of 4 negative experiences, but the red dot is Asian Americans, and it's 45%. And then conversely, down here in the blue box is this, they were also asked, did anyone express support for you in that time? Of which we have also about half of Black Americans who experienced it said they did get someone who expressed support, and under a third of the Asian respondents. And so I think that this is one of the few times where there is actual sort of data on how often this happens in a population-based way. And I think there's a lot of assumption that this is probably underreported. Underreporting is well documented among Asian American communities. There's underreporting discrimination, but for two reasons. I think there's a resistance, as well as this particular survey is conducted only in English. Probably a third of Asian Americans in the country have limited English proficiency. So the surveying would really have to be done in other languages as well. Personally, it does feel a bit underreported because I feel like everyone I know has either experienced one of these incidents in the last year or has a friend or a family member experience it as well. But on the flip side, that's the end of one story for me at any rate. So, but that is what examples of civic ostracism. And then relative valorization. Relative valorization, what is most often talked about amongst Asian Americans is what is considered the model minority myth. And this is the stereotype of Asians being high performing, highly educated, highly successful. This is a magazine cover from Time also, but as a contrast for you, this is from 30 years ago, 40 years ago. This is in the 1980s. And again, really starting to push this idea of Asian Americans are successful. And the interesting origin of that is it really started in the 60s, almost in concert with the rise of the civil rights movement, that documenting the success of Japanese Americans despite internment, the success of Chinese Americans despite mostly being excluded from immigration, was advanced as a narrative to kind of then lay blame on Black communities and saying, if you aren't successful the way Asians are, and it's a matter of personal responsibility. And so, right, this very much is consequential when it comes to higher education admissions. So what happened recently? A few years back, one of the prominent affirmative action cases in which it was actually sort of revisited twice by the Supreme Court, where white plaintiffs sued University of Michigan or Texas. I'm mixing them up. Abigail Fisher, maybe Texas. But at any rate, the court, one of the justices had said they ultimately concluded that universities could still consider race as one of many factors in admissions. But one of the justices had expressed a concern that Asian Americans were being disadvantaged in affirmative action processes. And so this organization, SFFA, which is Students for Fair Admissions, which had bankrolled and supported the white plaintiffs, now worked to identify Asian plaintiffs who could come forward and say they felt that these policies were discriminating against them. And so the most prominent one was they led a suit against Harvard, but they have actually also started lawsuits against 4 other universities. And again, one of the interesting parts, though, is again, really, this is trying to conflate what they are saying is that considering and perhaps giving preferences to other groups who are perhaps Black or Latinx groups is disadvantageous specifically for Asian Americans is the argument they are trying to make. Within higher education, though, there was a very strong pushback where they felt that the plaintiffs are making a difference between affirmative action and negative action. And what they mean is that when we look historically at admissions, with respect to race considerations, Asian Americans tend to be potentially victims of negative action in the sense that they are less likely to be admitted relative to white applicants. And this can be secretive, which plaintiffs argue, which is there are hidden quotas. This goes back to the Ivy League universities and having quotas for Jewish applicants. There's a sense of it's the same for Asian Americans. Certainly in Harvard, for instance, they pointed out that the relative representation of Asian Americans has remained flat, even as the applicant pool has grown to have higher representation of Asian Americans, suggestive of a quid quota, as well as implicit bias. And this we have seen in research that in letters of recommendation, in review evaluations for college admissions, that they may be more likely stereotyped as deferential and lacking creativity. And that this is considered part of the negative side of the model minority myth, that they're high achieving, highly educated, but because they are machines, because they are robots. and that they are subconsciously held to higher standards in admissions review. And so these are examples of negative action that there is limited evidence to suggest that this does in fact happen for Asian American applicants in admissions. And so the problem that really comes with the lawsuits is this argument that these negative actions happen because of affirmative action. And affirmative action is a different proposition. It is that in consideration of historical context, of contemporary context, that certain groups are going to be recognized both for the structural adversities as well as the structural advantages that are given to white applicants. And that's why we consider race and ethnicity in admissions. So the interesting part about all this is the same thing with the admissions literature in research and higher education. There are couple interesting things. One was an analysis. We had a proposition called 209. California was probably the first state to eliminate consideration of race and ethnicity in admissions. There were a lot of studies showing that representation of Black and Latinx students fell off a cliff, basically, in those first years after there was an affirmative action ban. What has not been as well recognized is that the Asian American acceptance rates also declined, particularly at the flagship schools, Berkeley and UCLA, after Proposition 209 was passed. This was masked because overall Asian American representation at the UC schools has gone up. But to the best that researchers can tell, it's because the applicant pool proportion of Asian Americans went up, because Asian Americans became a much larger demographic of the California population. So the representation has gone up, but their actual acceptance rate relative to how many are applying has gone down. And similarly, what we see in California medical schools is the same thing. Overall increase in the percentage of Asian Americans in medical school. And certainly in California medical schools, I think at the public universities, it is sometimes approaching 40%, depending on the campus. But a same thing, the overall relative to the population growth of Asian Americans in California, the representation in medical schools has also gone down. And so this is one of the confusing pieces, right? We can say there's so many Asians in higher education, there's so many Asians in medicine, and at the same time, there's some truth also to them not being represented, which is why people will bring lawsuits. The problem is that this has come after we got rid of affirmative action, not because we have affirmative action. In national surveys, 70% of Asian Americans support affirmative action, but there's really large variation across groups. The latest survey from AIP Political Voters that, for example, Chinese historically in the last several years have had the lowest level of support. This year was 56%, which is actually higher than the past. Sometimes it's as low as maybe 37, 38% of Chinese support affirmative action. Asian Indians, on the flip side, 86% support affirmative action. There's generally high support amongst Koreans, Filipinos, and Japanese Americans. So how Asian Americans feel about affirmative action, the implications for them is really mixed and much more complicated than these lawsuits would suggest. So getting to the specific part, what was really interesting to me was I just reviewed actually an article for a journal, and I can't speak about the article in the journal, but I wanted to point out that one of the reviewers wrote that the authors didn't give credit to medicine for how much Asian Americans have been fully embraced by medicine. And they used that word, fully embraced. And it was interesting. So I just wanted to remind everyone sort of the history, which is, this is from 1901. The American Medical Association was very much an advocate for the Chinese Exclusion Act. Part of the work of the AMA, of the AAMC, and the Flexner Report was to establish Western standards and also discuss how other groups and other cultures and their healing practices were inferior, not acceptable. And so it's just a reminder that it wasn't that long ago that Asian Americans were still in the yellow peril position, even within the profession. So then how do we apply this racial triangulation theory? Again, we have this relative valorization comes out with this minority myth. We have a lot of representation in medicine. The interesting part too, though, is then over the years, the AAMC has really struggled with how we should work on diversity. And what that manifests as is this very awkward term, which is non-underrepresented minorities. And that pretty much was a term that was coined to address the issue of Asian Americans. So one of the pieces that was not perhaps completely, has not been discussed a lot is why do we have so many Asian Americans in medicine when it feels like a lot? Like I said, if it's 40% of medical students, it's 20% of physicians nationally. It's much larger than population representation. Rather than the whiz kids narratives, which focuses on cultural values and personal responsibility, a couple other scholars have talked about this process of hyperselectivity, which is really, we have to think about, part of it is immigration history and immigration policy. Asian Americans, immigration was barred from Asian countries for a very, very long time, and was not fully opened. And I don't even want to say fully open, but not, we went from quotas to complete elimination from 1924 really to 1965. There were a few exceptions in between, but for the most part, it was very restricted. And so what happened then, though, is 1965 comes and immigration is highly selective. So this is what they mean by selective inclusion. A lot of immigration from Asian countries was allowed for the purposes of coming for higher education, was permitted for the purposes specifically of filling out our healthcare workforce. There was a nursing shortage where there is always a nursing shortage. There's a sense that we needed more physicians. There was a sense that we wanted to bring in the best and brightest in STEM fields. And it was also for those coming from Asian countries within higher education considered more feasible. Even if you were, say, a political scientist in your home country, your language abilities would make it difficult for you to be a political scientist in the United States. So, for example, one of my father's friends who in that position was like, well, maybe I should learn engineering because I won't be discriminated against for my English ability. So then there are two things what they talk about with selective inclusion and hyperselectivity is not just that you select people who are coming for higher education, but that specifically you get the people who have already been in a higher education position or coming from a country that has that infrastructure to make it possible. So that what happened was from certain countries, immigrants came to the United States from Asia having a higher level of education than where they were coming from, as well as the United States, meaning we had a lot more Asian immigrants with bachelor's, master's, and doctoral degrees, much more so than the rate of their own country and much more so than ours. So then there is the first, you have a first generation and then spillover effects of subsequent generations, as well as knowledge, education, and cultural resources that are distributed to the community, even as immigrants who don't have that background come in. So there's the idea of you start with a highly selected population and then you have spillover effects. You have suddenly you have a pool of people who tell you how you're supposed to do on the SATs and how you prepare for that and set that cultural norm. And this is the idea behind part of that. The selective immigration policy contributed quite a bit to Asian American representation in medicine specifically. And I just realized this is a slide with animation, but in this background, it's not working. So I apologize. So why is we called Not Underrepresented? At this point now, what we see is in 2019, 17% of all active physicians in the United States, 17% were Asian American. And so this is what they mean by why is this not underrepresented? Because it's far larger than the proportion of population. The tricky part is then what happens is you still get this triangulation. And I apologize, this part is obscured, but you see that paragraph in the lower left-hand corner. In 2021, so just last month, there was a research letter that was published in New England Journal of Medicine looking at 50 years of diversity in medicine as a profession. And they talk about how the share of white men as a proportion of all physicians has really come down over the decades. And where we've seen a lot more representation is in Asian Americans, men and women, and then in white women. But what I wanted to highlight is, and this is something I've been concerned about, so I definitely really want to change that distribution myself, but I want to highlight the triangulation piece in which the language that they use is regrettably, however, we have this, and then because we have let in more white and Asian women, and then this other quote, same thing. It was like, we have more white, the decline in white men is offset by the rise in Asian men. And it's not that it's not exactly true. It's that the language is really putting the Asian Americans in this position of polarizing against other minorities. And so I just wanted to highlight this example of this. Even this happens in medicine, or maybe more so. So what is the actual experience of Asian Americans? So there have been a limited number of studies, but really getting at this issue of having high representation. 2020, it's 22.8% of enrolled US medical students versus inclusion. So previous studies have shown we have high representation. Asian American students are less likely to be awarded AOA status than non-Hispanic white students when controlling for their clinical performance or standardized test performance and activities. In their letters of recommendation, they're less likely to be described as empathetic, compassionate, exceptional, or outstanding. And then just a limited qualitative research on Asian American students themselves. They discuss how they feel like a lack of role models, lack of encouragement. They are discouraged from pursuing careers in academic medicine because medical schools will just forget about us. And then again, limited studies on Asian American physicians. There have been repeated studies showing that they tend to have lower patient satisfaction scores. And I think most recently, this just came out in fall of 2020, average lower Press-Ganey scores, which was found to be due to having a higher proportion of Asian patients, that Asian patients in general tend to provide lower ratings. And so then what happens is if you have higher Asian patients, you are going to have lower ratings. And I thought that was interesting, both for the looking at causes, what do we think this says about Asian patients who are rating, but also I think knowing that would that subconsciously deter someone from having Asian patients. Another study that just came out in winter of 2020, a survey amongst residents and their experiences of discrimination. Asian American residents have the highest prevalence of being subjected to belittling and demeaning behaviors from patients and from colleagues. And then an older study, unfortunately, I haven't seen an update, of a national survey of physicians, and over 45% reported experience racial and ethnic discrimination in their professional lives. This was similar in the national population, second only to Black physicians experiencing discrimination in their practice, in their work. And then certainly within my own work, what I can see when I look up data on medicine, on health workforce estimates, they usually don't include Asian Americans. They might, or they combine it with whites. That a lot of graphs and statistics I see tend to be underrepresented minorities broken out, and then non-underrepresented minorities as an entire group. And so that is very much a way of making Asians equivalent with whites, even though we know their experiences are not equivalent. So that gets us to one of the first steps that is really being requested by the AAPA community in many different ways, but is also something that needs to happen in medicine, is data disaggregation. And data disaggregation is simply, we need to look at, so far, I have been talking about Asian Americans as if they are just one big homogenous group. Clearly they are not. So one of the first things we need to do is really unpack that and identify different groups. And to that, when aggregated as a group, Asian Americans, when you look is relative to other also aggregate groupings, have the highest levels of within group inequities. And what I mean is there's the biggest income gaps, the biggest educational gaps within a racial group are within Asian Americans. And so you can see on the lower left-hand side, Cambodian, Hmong, and Laotian communities have much lower income levels, much lower educational attainment, and really in contrast, and that is relative, they have higher poverty rates than white Americans, and very much in contrast to what we see over here, which is Indian Americans and Taiwanese Americans who have far higher incomes on average and educational levels. That the number with a college degree is over 75% for both of these groups, and under 40% for a high school degree or less, high school degree or more, sorry, is under 40% for these groups. So there's a real importance of not lumping all the Asians together and saying they're all successful, they're all highly educated, they're all affluent. And I want to make a note too. I've been talking to Asian Americans, and there's a really interesting debate going on now as to what extent people who identify as Pacific Islander and Native Hawaiians want to continue being part of the group. This is a quote from a perspective published in JAMA last year, and it's one of the few, if possibly only, Native Hawaiian or Pacific Islander medical school faculty in the country. There's only a handful. And what Dr. Tapara is arguing here is that combining them together is really, from their perspective, disrespectful, because they have completely different histories of oppression, relations to the United States, as being continuously being colonized. And it's so, there is a lot of debate as to whether or not we should keep saying AIPI or not. And in fact, even in the 90s, under President Clinton was when we started collecting separate data for Native Hawaiian or Pacific Islanders. And this has really been important during COVID-19. The NHOPE groups have had incredibly high death rates, particularly Samoans, during the pandemic. And there's a lot that intersects with history of colonization, with socioeconomic status, as well as occupation. And you may or may not have heard this, there's certain Pacific Islander groups that have been sequestered into high-risk occupations, whether it's in agricultural and food processing or such. And so, again, there's a real argument to be made for data disaggregation, Native Hawaiians or Pacific Islanders separately, and then within Asian American subgroups. Another example of really needing to differentiate is Filipino Americans have borne a really high brunt of the COVID-19 death toll amongst healthcare worker deaths. So in California, 80% of healthcare worker deaths are accounted for by Filipino Americans. They account for 4% of nurses, but 31% of nurse deaths due to COVID-19. There is a very, very limited disaggregated data on Asian Americans. So a couple of the bullet points I have here are from a blog post that just came out in Health Affairs, where they're saying this is the best we can, but we honestly have very little information. So for example, we don't know anything nationally. We know, for example, one study in New York City public hospitals that Chinese Americans had the highest COVID mortality of all groups. Their mortality rate was 44% higher than whites in New York City. Indian Americans had the second highest COVID hospitalization rates. But even stepping back and going broader, for a long time, Korean Americans have had the highest rate of being uninsured in this country. A lot of the gaps were closed more so during the Affordable Care Act, depending which state they lived in. But nevertheless, Korean Americans consistently still have higher rates of being uninsured than most other racial and ethnic groups, not just other Asians. So the reason to disaggregate is really because we need to think a lot about different groups having different histories and origins. So, and I'll get to this in a second, when I talk about hyperselectivity, truly that really only applies to primarily Chinese Americans, Taiwanese Americans, Indian Americans, maybe the first wave of Vietnamese Americans, just that very first one, but not the subsequent ones, Koreans. And so what you can see here, unfortunately, this is from 8 years ago. I have not been able to find anyone who did this more recently. When they disaggregated the Asian groups amongst physicians, who again, we say are not underrepresented. The reality is that Asian American physicians at that time, 39% were of Indian or Pakistani origin, 15% were Chinese, 6% Korean. Filipino and Vietnamese Americans together make up 25% of the Asian American population, but actually only 8% of Asian American physicians. And we have no estimates on Hmong, Laotian, Cambodian physicians, despite being the groups with the greatest socioeconomic inequalities and disadvantage and healthcare access, linguistic access problems out of all Asian Americans. So when we say really who's not underrepresented, we need to disaggregate. We need for people on admissions, people in medicine to understand that there are different Asian groups and recognize they have different needs. And certainly, for example, recognize that being Hmong or Laotian is completely, utterly different from being Chinese American. As I said, that hyperselectivity, you really had to come from a country that had that infrastructure and that you came in this education pathway, for example, or through family members of highly educated members pathway. We have to understand that a number of other Asian American groups are really here, not only through change in policy, but due to American imperialism. The Filipino hyperselectivity is really specific to nurses, for example. When the Philippines was an American colony, there was this whole push to say that Filipino nursing education was inferior, and then to implement a Western nursing education in the Philippines. And now it has come back around and saying, we create pathways for Filipino nurses to come because they have been educated in a Western style. So similarly, remembering that Asian groups are also here as a result of conflicts in which we had a hand in them. And they are going to have different stories of historical trauma, intergenerational trauma that are in part tied up with the United States. And then the last piece we need disaggregation for is because we also have to understand that there's racism and colorism amongst the Asian subgroups. When we dial back and I say who brought the anti-affirmative action lawsuits, the biggest proponent has been, and the biggest advocates for these lawsuits has been a select number of Chinese American groups. They've also gained support from a few Indian American groups, and those tend to be the plaintiffs. And so there is a long history of, for example, East Asians and their racism against Southeast Asians. And it is being played out and relitigated again in our own country. And I think that's something that's also not as well understood, even when people talk about admissions, is this dynamic that is happening. And why people say, well, how come some Asian Americans are complaining about admissions and others are not? There is the intergroup dynamic that has to be accounted for. So, and then just most recently, another reason we need to not just disaggregation, but really talking about inclusion within our own field is because we are over a year later. Everything that Dr. Fu expressed in his video essay is simply back again, has never gone away. There's an op-ed published in Stat where a couple Asian American residents wrote in and said, we felt supported, period, temporarily after the Atlanta shootings, that the feelings, people are basically still in the same place. They're still working very hard, still taking care of COVID patients, still worrying about or experiencing racism in their day-to-day lives. The trainees, particularly I think because they're working so hard, is there recognition that they have to be in fear of just leaving their homes every single day. So in that, we have a little time left. I was going to give everyone about 10 minutes or so and put you in breakout rooms, if you all don't mind. And we're going to sort of brainstorm a bit. What can we do in medicine? What can we do within an institution, within a school, to both advance the inclusion of Asian Americans, but also really engage them in DEI work? Again, we're in this middle place. We have representation, we have numbers, and how do we turn that into though inclusion and not just this dialogue is about white doctors, this dialogue is about not enough underrepresented doctors. Like, what do you think in your school is going to help sort of continue to advance conversation? And so I've created, I don't know if anyone's had experience with this, but I've created something called Google Jamboard. This is a set of slides that you can all work on together. So we'll put you in groups and then you just go to the board that corresponds to your group number. There's 10, but I don't think we need it. that many. It looks like there's 27 people, so I'll put you in about 6 breakout rooms. Go to the board, and you can use the board. There's stickies, there's text. You don't have to, but this is just another way to sort of facilitate working together. So I'm going to go ahead and put people in breakout rooms. Is it okay, Dr. Pang, if I just assign them automatically? Okay. Okay, so you should all be getting an invitation to go to a room, and then there are 2 questions, and I am happy to just hop around, and I hope Dr. Pang and Dr. Sanchez, I'm calling on you too, you can also hop around, and then we'll call everyone back in about 10 minutes or so. Often in these sessions that we end up having to close down just when we really start getting going. But I hope that went well. I see a lot of different boards have some ideas on them, and we just have a few minutes left. So I just wanted to ask, did anyone feel like, questions came up that you wanted to bring to the bigger group in doing this exercise? And then for Dr. Pang and Dr. Sanchez, you have the link to this, so you have a lot of the ideas that came out. Anyone have any comments, thoughts?
Oh, I would actually like to invite Dr. McGrew to speak for our group.
Oh, are you going to be able to put those boards up for me? She did not give me any warning about that, I have to say. So.
What was your group number? Do you remember? Oh, there we go. Got it. Yeah. Go ahead.
Well, we talked a lot about strategies in academic medicine, and one is just, generally education, just resources nationally, that we all have to educate in the same story. We can't just depend on Asian Americans to educate us. It's our responsibility to educate ourselves as well. The other is to be really conscious of leadership on campus and to make sure that folks know what is available and to really promote Asian Americans to apply for jobs. And we talked about specific folks now who hold jobs that it's really important, but also to really look at ways to develop people for leadership. And I expressed my own concern about leadership courses in general. I mean, some are great, but even as a woman, sometimes I find that they don't address the different ways that people lead. They're developed on one paradigm of leadership that may not fit for women or people who are underrepresented in medicine or other people of color. So that was a little bit of a plus minus. But then some strategies to engage Asian American trainees, and you have nothing written there, Joyce, but as I remember, it was a lot of reach out into the community to connect leadership in higher ed, and particularly for us in the School of Medicine, in leadership to those who we might nurture along the way to enter healthcare professions.
Great.
I just also think in following up to Dean McGrew and Dr. Koh, just to also share, Dr. McGrew is our Dean of our School of Medicine, and he's been really calling everyone on this call and for all of us to invite people to apply for various positions that are posted. So right now, she just released the call for people to apply for the Executive Diversity Officer position, and we definitely want candidates. We absolutely want candidates from the Asian diaspora. There's also been a call for future chair positions and other positions. So, I think that level of inclusion is one component of many components that you noted.
Mm-hmm. Great. Well, we've only got a minute left. I did want to share one last thing, which hopefully there's going to be a little bit delay. It was just something actually that I just came across yesterday, but I happened to like quite a bit. There are 2 websites of 2 initiatives that are happening right now that are not about medicine specifically, but in terms of when you're looking at education, right, and activities and things that you could do. There's one called solidaritystories.org, and then another one which is CS Unite. I haven't actually seen as much with CS Unite's videos, solidarity stories. They really highlight not just only Asian American history, but really a history of solidarity with other groups. And they have activities that and guidance around how you can use this story and suggestions for ways to use this, the different stories in a teaching setting or different stories in a workplace workshop. So I just thought I would share that with you. And that is it. Thank you again so much for inviting me. Again, it was a real pleasure, and I feel free if to follow up if you have questions or other thoughts. And I'm wishing you the best of luck in the work that you're doing.
Thank you.
Well, can I just also say thank you again to Dr. Pang for bringing us together for this session, and Dr. Ko for fitting us in. I know it's a little bit of a last minute request, but we really, really appreciate the whole Health Sciences Center. So thank you so much, and we look forward to working with you more.
Oh, for sure. It's an experience for me. I've never been invited to speak on this topic before, so it gave me a lot of good food for thought about what I would do as well. And I'm happy I could. Dr. Chan is got a similar role to yours, so he's super, super busy. So I'm glad that I could fill in on that in that capacity. Yeah, and we'll keep moving forward.
I know there's also a lot of interest from individuals who couldn't make the session to see it on the recording. So the recording will be available on the website as well, and we'll share that with you as well. Okay,
sure. And yes, everyone feel free to keep on putting ideas in the Jamboard if that, it's nice to realize, I find all the time that a lot of people can have different ideas, and it's great. I'm always learning from other people. So it's the same thing within institutions, as well.
Thank you so much for joining us today, and just really appreciated the talk. And I agree, a continued dialogue is really, really important. And the Jamboards were great. I actually had never used them before, so that was just excellent.